And poor interagency reporting and liaison. And again, the Climbier inquiry, I think, is probably the starkest example of that, where we don't work together across boundaries and different agencies. So, where could we see all this happening? Winterbourne View. For me, I saw all of that there and more, but you could see it very clearly there. So, last summer, almost immediately after Panorama, I think it weren't very long after, I was asked to do an external review. I was asked to look at the safety and the culture of the services at Castlebeck, and that was the hospital services at that point in time. That report will be on the website today, if anybody wants it. There will be a few hard copies available today, but we couldn't carry many, but you'll be able to get it as a PDF. So I'm not going to go into too much detail, I'll just give you the headlines. There's also an easy read version for people with learning difficulties, if they wish to have a look at that. I did 12 site visits to these hospitals between June and August 2011. Didn't do Winterbourne View because it was subject to police investigation. I couldn't walk across it because obviously they were collecting evidence actively at that point. I did looked against what's known as the Confirm and Challenge Framework, which is a self-assessment tool that I developed some years ago, and I used that as really just something that's a benchmark for me to be able to measure each hospital against. I did a review of the literature, which I've mentioned. Importantly, interviews and observations with people who use services and their families. Did lots and lots and lots of talking to individuals. Spent a lot of time speaking with families, did open surgeries, and then obviously some families who, for reasons of age and frailty, we did telephone interviews, but we managed to capture lots and lots of views. Observations at key meetings. So I went to a service user forum, staff meeting, that was interesting. Confidential interviews with staff. Now that first bit's really important. The brief I gave them were very specific in terms of the expectations of this review. For me, given what had happened, I felt it were absolutely critical that their interviews were confidential. This were a workforce at that point that were extremely, stressed, if you like, and a service user group, and similarly for families. So all interviews were done on a one-to-one basis with me, and they were all confidential. And we also took a diagonal slice. So I asked housekeeping, administrative staff, nursing, clinical and training. It weren't just the caregivers, if you like. And then I did confidential interviews with the executive team that was in place at the time, which is not in place now. I did an analysis of documentary evidence, rotas, MDT, CPA meetings, notes, nursing, clinical notes, usual things. And for me, importantly, again, I did a summit with the key stakeholders, including service users, and played back to them what I'd heard, and then asked them to inform me about what they thought my recommendation should be. So I kind of did that, This is what I think I've seen, this is what I think you've told me, this is what I think you want to happen, is that correct? And from that, there were 9 key areas. Do you want to just flip these up for me? Thank you. Assessment and care planning and therapeutic interventions, multidisciplinary team working, planning and delivering person-centred care, a meaningful day, environment, workforce, structure and culture, commissioning and clinical governance. So I'm just going to briefly go through these, just give you some of the key lessons, maybe to think about with other providers, but also, depending on what role you've got, in terms of commissioning packages of care. As I've said, we need to ensure there's a clear purpose and focus for inpatient provision. There is only one clear purpose for inpatient provision in current policy, and it's embedded in the Mansell report, and it's very clear, and I put it in speech marks. It is the short-term assessment and treatment for psychiatric conditions only. Not for admitting people just to see how they're going with the behaviour, or we're not sure how he is, so we'll admit him and see how he goes on. They should only be going in for that very reason. That is the only reason somebody would go in a psychiatric service in the mainstream. So why would people with learning disabilities be any different? Now, it might be when you admit them, you decide through assessment that they haven't got a psychiatric illness, it's something else. But the purpose is that, yeah? Agree the admission criteria and proper care pathways and individual outcome measures. I think it's really important that we don't do that waffly, you know, the outcome will be, we'll sort out the behaviour. You know, I want to know what, where, when and why. Making sure special means special. If somebody's admitted to a specialist service, I want to know what special qualifications those staff in that special service have. Sometimes I'm asked to review specialist services, as I were in this case. And again, an easy test is to just say, can you get your staffing establishment out? And do you want to tell me, of these staff, who's got qualifications that could deliver treatment programmes? Of these staff, who's got qualifications to support people who've got, you know, psychiatric illnesses? And often what you get back is a couple of MVQs and some staff who are registered first level with no postgraduate certificates or qualifications. So who's delivering the programmes? Create a meaningful day. I'll not dwell on that, but combat boredom. And promote healthy lifestyles. Again, we've heard from the serious case review that were not attended to. Those people who know me know it's a passion of mine. I were involved in writing the second health action planning guidance and feel very, you know, clear in my views that we need to make sure people have healthy lifestyles, and that means, you know, not just good diet but good exercise for the mental health as well as the physical. And invest in good care planning, but involving people and families in that, you know, not to be an activity to one side, to make sure that this is truly done. Many of the people I've met in services often have a person-centred plan, but really it's key worker that's filled it in. You know, it's not a live document. It's not involved in the day-to-day care delivery. So one of the things I'm keen on is not to kind of get hung up on having person-centred plans that look like this, that actually in the care plan, can we see evidence for a person-centred approach? Are person-centred thinking tools embedded in it? Is it accessible? Has the person been involved in developing it with the staff? Let's put these up together. Multidisciplinary team working. I think that it's easy to divide and rule in services. I think when you do that, I think when you've got if you like a dysfunctional multidisciplinary team, it's easy to blame each other, and it's easy to say it's somebody else's responsibility. So I think if in inpatient provision, we need to have a very clear view about who's responsible for what. And also make sure that their footfall's high. Some services I've seen very little involvement other than from nurses and psychiatry. And again, I think that were a characteristic of Winterbourne View. But it's not just Winterbourne View. You know, people need to be visible. They need to be sitting in day rooms or lounge areas or wherever it is that service has. They need to be there. They need to spend time with a cup of coffee and not be dashing in, doing assessment, dashing out again. Defining the role of the named nurse and the key worker. Defining it so that they're accountable. If somebody hadn't had an assessment and it were meant to be done on the 3rd of June, then I'll hold them accountable for that. I'll hold their named nurse accountable. Now, if they say, well, it were meant to be a psychologist and she hadn't been and all of that, I'm not interested. So what have you done then to change that, to make that happen? Have you nailed her down to come in next week? What have you done?